Hello, my name is Dr. Scott Brancolini, and my topic today is painful disease states from the Advanced Topics in Anesthesiology, Section 2D1. I am the Chronic Pain Medicine Fellowship Director at UPMC and an Assistant Professor of Anesthesiology. I have nothing to disclose. We're going to go down the list of topics one by one, which are all outlined and according to the exact outline that was provided by the advanced topics list. Typically, pain medicine can apply to the advanced or beginner stage, and the slides are not designated between step 1 and step 2 of the exam. They will apply for both of them. First, we'll begin with talking about acute pain. Acute pain is typically when an injury has occurred and healing occurs during the normal appropriate period. Acute pain is not typically associated with secondary gain. It is often thought that social, cultural, and personality factors might play a role. Acute pain typically responds to treatment, and improper therapies could potentially result in the development of chronic pain. Next on the topic is a definition of cancer-related pain, and then after that we'll begin a discussion of chronic pain. Cancer-related pain typically requires a very detailed oncologic history. It's important to diagnose, stage, discuss the history of therapy, chemotherapeutic agents used, whether or not radiotherapy was used, and it's important for the patients to understand the process and prognosis of their cancer diagnosis. It's very important for a physician to obtain an excellent pain history, discussing things that are palliative and provocative, the quality of the pain, the radiation of the pain, the severity and the site of the pain, and the timing of the pain. In order to properly elucidate whether metastatic sites are causing the cancer pain, a full review of radiologic studies are necessary, as well as a psychosocial history, thorough past medical history, review of systems and physical exam. All of these are used in combinations with also multimodal techniques for care team meetings. Typically, cancer pain is divided into several categories. Acute is less than 4 weeks, subacute is 4 to 6 weeks, and chronic cancer pain is over 6 weeks. It's important to recognize that cancer pain can be characterized by breakthrough pain, which is one of the most important facets of its difficulty in treating. Cancer pain may be a cause of somatic pain, which is a constant, well-localized pain. Somatic pathophysiology typically refers to a very well-defined nociceptive type pain. It is responsive to opioids, NSAIDs, and neural blockades. Cancer pain may also be visceral, which can include the sympathetic nervous system innervation. It is typically described as a vague, deep, dull, aching pain. Cancer pain can be neuropathic, caused by post-thoracotomies, post-mastectomies. Chemotherapy-induced pain can cause neuropathic pain as well, typically cisplatin, vinca alkaloids, paclitaxel. Neuropathic cancer pain can be treated with opioids, TCAs, anticonvulsants, oral and topical local anesthetics, steroids, and NMDA blockers. Causes of cancer pain can be associated with spinal cord compression, plexopathy, oral mucositis, painful polyneuropathy, post-surgical pain syndromes, headache, and cervicofacial pain syndromes. Further causes of cancer pain are bone metastasis. Typically, bone metastasis may be seen in stage 4 prostate, breast, thyroid, lung, or kidney cancers. Cancer pain can be constant, dull aching. It may be increased by movement. Cytokines and PG-E2 may be increased. Vertebral body metastasis may be the first sign of cancer pain in some of these conditions. There also may be meningeal metastasis from breast, lung cancer, which diffuse infiltration of the meninges can cause headache and back pain. This can be confirmed by lumbar puncture, which may result in cytology of malignancy. Okay, so moving from cancer pain to chronic pain states. We defined acute pain, we defined cancer pain, now we will focus on chronic pain. Pain is typically defined as an unpleasant sensory or emotional experience associated with actual or potential tissue damage or described in terms of such damage. This is typically pain that extends beyond the expected period of healing. Most commonly used chronological markers for chronic pain are 3 months. However, sometimes 6 months is used. These distinctions are often arbitrary. Chronic pain syndrome is separate than chronic pain. Chronic pain syndrome entails a type of pain that is greater than 6 months. There may be some mental health impairment. There are typically higher rates of healthcare use. There is typically impairment with respect to vocation, socialization, and emotional issues. There may be issues of secondary gain, and addiction may or may not be present with chronic pain syndrome. The next topics are to review things such as acute and chronic neck pain as well as lower back pain. One of the topics to be discussed is cervical myelopathy. Cervical myelopathy can cause acute or chronic neck pain. It is associated with the spinal cord dysfunction in the cervical spine. Typically, these patients present with a loss of fine motor control in the hands, paresthesias, gait abnormalities, or changes in their deep tendon reflexes. Pain is usually rare. An accompanying physical exam sign may be Lhermitte sign, which is an electric shock sensation with neck inflection or extension. Typically, cervical myelopathic changes are best seen in a T2 MRI. Cervical myelopathy extrinsically can be caused by cervical spondylosis, central disc herniation, posterior longitudinal ligament ossification, rheumatoid arthritis, spinal tumors, and epidural abscess, which is most commonly associated with Staph aureus. Intrinsic causes of cervical myelopathy may be due to viral infections, neoplasms, vascular disease, motor neuron disease, radiation, and nutritional myelopathies, as well as syringomyelia. Cervical radiculopathy is typically described as a pain that is a unilateral radicular pain accompanied with paresthesias in the upper extremity, typically in a dermatomal distribution. There may be weakness in a myotomal distribution, which is an affected group of muscles noted, and there may be, after extensive radicular symptoms, atrophy in certain muscle groups in the upper extremity. Discogenic neck pain is separate from that prior cervical radicular pain. It is characterized by the outer third of the annulus fibrosis, and acute or repeated trauma can cause discal tears. The outer third of the annulus fibrosis is innervated by sinovertebral nerves and the gray rami communicans. Discogenic neck pain may occur with simple Valsalva maneuvers, such as a cough or prolonged seated positions. In separate pathology is cervical myofascial pain, which is usually a dull ache that results from taut musculoskeletal bands, typically reproducible upon palpation. This is distinguished from fibromyalgia, which is typically referred to as a widespread pain. Conservative treatment of cervical myofascial pain is usually massage, heat, cold stretching, and TENS unit. Trigger point injections may be helpful to target the area that is bothering the patient. So shifting from the neck to the back, we'll now discuss causes of acute and chronic lower back pain. In quick summary, the lumbar spine is made up of 5 vertebrae, separated by intervertebral discs that act as shock absorbers. Each unit contains a body and an arch. The vertebral body consists of a pair of pedicles and a pair of lamina, which enclose the foramen. Fortunately, the vast majority of lower back pain complaints are of a benign etiology and are often self-resolving. 50% typically resolve in 1 to 2 weeks, 90% resolve in 6 to 12 weeks, and 85% recur in 1 to 2 years. Pain persisting greater than 4 to 6 weeks requires typically a further workup. A physician needs to be aware of red flags for an earlier detection of a more serious etiology. What are the differentials in regards to lower back pain? Lumbar strain and sprain, which is the most common, lumbar degenerative disc disease, trigger points, fibromyalgia, spondylolisthesis, and sacroiliac sprain and sacroiliitis. Spondylosis is typically referred to as a degenerative OA of the spine, where spondylolysis is a pars fracture. Spondylolisthesis is a forward displacement of the vertebrae. Other things that can cause lower back pain include disc herniation, discitis, radiculitis, stenosis, cauda equina syndrome, compression fractures, scoliosis, aortic dissection, and abscesses. Therefore, it's very important to pick up on red flags so as not to miss something as important as an aortic dissection. Other things that can cause a differential diagnosis of back pain can include prostate hypertrophy, cancer, psoas spasm, bone tumors, central canal syrinx, tethered cord, osteomyelitis, Pott's disease, Charcot joint, and also consider simulated complaints such as primary or secondary gain, which may be seen with patients on opioids chronically, Munchausen's, psychogenic causes, or workman's compensation. Additional things in the differential diagnosis of lower back pain can include congenital or developmental anomalies such as fibrous dysplasia, sacralization of L5, asymmetrical facets, and sacral ribs. Ankylosing spondylitis can cause lower back pain. Reiter's syndrome, inflammatory bowel disease may radiate to the lower back. Paget's disease, aortic aneurysm, and intermittent claudication. It's important to be able to pick up on the red flags of lower back pain. For example, Has somebody had a history of cancer? Do they have an unexplained weight loss over 10 kilograms within 6 months? Age over 50 or age under 17? Is their pain persisting more than 4 to 6 weeks? And is their pain at night or at rest? Another important red flag in lower back pain is persistent fever, bacterial infections, history of IV drug abuse, immunocompromised states, and recent interventional procedures to the spine. Other red flags in the differential diagnosis of lower back pain can include Cauda-Equina syndrome, which is urinary incontinence or retention. Cauda-Equina syndrome is also associated with the saddle anesthesia, a loss of anal sphincter tone or fecal incontinence, bilateral lower extremity weakness or numbness, and a progressive neurological deficit. A herniated nucleus pulposus or herniated disc can typically cause nerve injury, resulting in major muscle weaknesses, a foot drop, absent DTRs, and is typically seen with a positive straight leg raise test on physical exam. Other red flags in lower back pain can include a vertebral fracture. Risk factors for vertebral fractures can include chronic steroid use, age greater than 70, history of osteoporosis, recent trauma, fall from a significant height, or ejection from a motor vehicle. And an abdominal aortic aneurysm is an important red flag in any evaluation of an urgent back pain situation, which is associated usually with an abdominal pulsating mass, atherosclerotic vascular disease, pain at rest, or nocturnal pain at age greater than 60. Now that we've covered the differential diagnoses and red flags associated with lower back pain, we can move toward neuropathic pain states, which are typically pain involving nervous system abnormalities. The prototypical example of a neuropathic pain state is referred to as complex regional pain syndrome. This is divided into two types, type 1, formerly known as RSD, and type 2, formerly known as causalgia. These states are characterized by the presence of an initiating noxious event or cause of immobilization. Type 1 is an assumed nerve injury. Type 2 is injury of nerve is not known. Type 1 is also characterized by continuing pain, allodynia, or hyperalgesia with which the pain is disproportionate, evidence of some time of edema, changes in skin blood flow, or abnormal pseudomotor activity, and finally, please be sure that this diagnosis has excluded the presence of other diseases that could otherwise account for this pain and dysfunction. One of the criteria in diagnosing complex regional pain syndrome was what is now known as the Budapest criteria, which includes the following. Number 1, presence of continued disproportional pain from the known inciting event. And number 2, at least one symptom in 3 of each of these following categories. The 4 categories are sensory, vasomotor, pseudomotor, and motor trophic. And you can see, for your reference, the types of symptoms that would correspond to the categories listed below. Again, it's one symptom in each of the 3 following 4 categories. Part 3 of appropriate diagnosis of CRPS via the Budapest criteria is the patient must report at least one sign in 2 of the following categories at the time of evaluation. Sensory abnormalities, vasomotor abnormalities, pseudomotor edema abnormalities, and motor trophic abnormalities. Examples of this can include hyperalgesia, allodynia, temperature and color asymmetries, swelling, sweating changes, decreased range of motion, and finally, no other condition that would otherwise explain these symptoms could be the cause of pain or dysfunction. Moving on in painful disease states that are neuropathic in nature, postherpetic neuralgia is classically defined as pain persisting for more than 1 month following the disappearance of the herpes zoster rash. This likelihood of PHN increases with increasing age. This type of pain may last for months or even years, and is thought to be the result of chronic inflammation and injury to the nerve. It is thought that substance P plays an important role in pain transmission, while others have noted that serotonin and norepinephrine are inhibitors of these signals. Postherpetic neuralgia typically is most commonly seen in the thoracic distribution. The treatment of postherpetic neuralgia acutely is antivirals, such as acyclovir, famciclovir, and valciclovir. The treatment of postherpetic neuralgia, after the rash is resolved, is TCAs, gabapentin, pregabalin, valproic acid, lidocaine, 5% patch, capsaicin cream, opioids, nerve blocks, and spinal cord stimulation. Moving forward, phantom limb pain is a neuropathic pain state typically referred to as a central type pain, defined as a painful sensation referring to the missing limb. It is primarily in the distal limb. Phantom limb pain is of a stabbing, pins and needles, neuropathic, tingling, throbbing, cramping, and crushing pain. Its prevalence occurs in 60 to 80% of patients who have had amputation, and the prevalence of severe pain with phantom limb pain is typically 5 to 15%. After amputation, the mean intensity 6 months post-amputation is 22 on a visual analog score scale of 0 to 100. The onset of phantom limb pain may occur 1 week to several years after the inciting event. Prevalence remains the same over many years, but as is typically seen, the severity may decrease over time. Phantom limb pain goals include attempting to control the pain prior to amputation. This is thought to help to reduce post-amputation phantom limb pain. These types of things that can be done include preoperative epidural blocks and postoperative regional anesthesia. The treatment of phantom limb pain may also involve further medication use, such as amitriptyline, nortriptyline, anticonvulsants such as gabapentin, pregabalin, other medications such as opioids, tramadol, and NMDA receptor antagonists. In some cases, neuroma excision may be beneficial. Central post-stroke pain syndrome is also a diagnosis of exclusion. It is a type of neuropathic central pain. Typically, it is seen in the area of the sensory loss. It is more common in thalamic type strokes. The pain is episodic or continuous. The quality may be burning or aching, but may be also lacerating or prickling. And finally, central post-stroke pain syndrome will be characterized by hyperpathia, hyperalgesia, or allodynia. Treatment of post-stroke pain syndrome may involve membrane stabilizers such as carbamazepine, intravenous lidocaine, aminergic agents as listed there, and N-type calcium channel blockers. I wanted to discuss also some neuropathic pain states and things that may cause it that are outside of what discussed already. Diabetes, alcoholism, uremic conditions, AIDS/HIV neuropathies, B6 deficiencies, chemotherapeutic agents such as cisplatin, vincristine, and other agents such as amiodarone and isoniazid may also cause neuropathic pain states. So moving from neuropathic pain states to neuropathies, we're going to discuss now peripheral neuropathies and different mechanisms and why this is thought to occur. Peripheral neuropathies can occur in the axon, in the myelin aspect of the nerve, or both. Neuropathies may be toxic, metabolic, viral, genetic, or immunologic in nature. Symptoms can be pain, pressure, decreased proprioception, decreased sensation, and temperature. The pain is predominantly thought to originate from small fiber neuropathies and the small unmyelinated C fibers. On exam, a patient with peripheral neuropathy may have noted atrophy, deformity, autonomic dysfunction, loss of distal reflexes, gait abnormalities, and decreased fine motor functions. Typically, diabetic peripheral neuropathy is seen in about 60 to 70% of diabetic patients. Patients may experience dysesthesias, painful paresthesias, sensory loss, decreased perception, proprioception loss, and in more advanced cases, weakness in the muscles, painless injuries may occur, loss of balance may occur, and proximal weakness may occur over time. The treatment of diabetic peripheral neuropathy is typically multimodal. It may involve antidepressants, TCAs, SSRIs, SNRIs. It is thought that tramadol is helpful due to its weak mu-opioid receptor agonism and its enhancement of serotonergic effects. Peripheral neuropathies can also be treated with topical creams and gels such as lidocaine or capsaicin, TENS unit, and mirror box therapies. So we've concluded with neuropathic pain conditions and now are moving forward with somatic pain conditions. The most commonly seen types of this pain are myofascial pain and facet arthropathies. We'll start with myofascial pain. It is commonly associated with many pain conditions, mostly in the elderly. typically associated with musculoskeletal structures that are often diffuse or difficult to pinpoint. The pain is usually described as aching and likely involves nociceptive specific neurons in the spinal cord and in the brainstem. It may be due to other phenomena such as tendinitis, muscle strain, inflammation, degeneration, or injuries to joints and nerves. The theory of what is called a trigger point is that the musculoskeletal pain may develop a taut, hyperirritable band that is associated with a hypersensitive, palpable nodule. Trigger point hypothesis is not a perfect theoretical concept, but there is comprehensive evidence-based models that show that using needle therapies, massage therapies, to break up the taut skeletal muscle band may be helpful in improving pain conditions. Trigger point injections are typically described as where palpation is the criterion standard for diagnosing these spots. Other ways to treat myofascial pain include education, physical therapy, trigger point injections as noted, and NSAIDs. In the neck, a type of somatic pain syndrome is facet-mediated pain. The facet-mediated pain in the cervical area are innervated by the dorsal rami of the spinal levels above and below the joint. An exception to this is the third occipital nerve, which innervates the C2-C3 joint. Cervical facet-mediated pain typically may be seen with patients who have focal tenderness. Just like in the neck, lumbar facet pain may occur in the lower back, in the lumbar region, in what is called a zygapophyseal facet arthropathy. Sensory innervation to the joints in the lumbar region are provided by the medial branches of the dorsal rami. However, in contrast to the cervical facet, the thoracic lumbar joints are innervated by the upper level and the level above. For example, the L4-L5 facet joint is innervated by the medial branches of L3 and L4. So we've identified a number of pain states, and now we're going to shift to painful disease states and how to treat them. So what we'll do is go through a lot of the acute postoperative pains, the post-traumatic pains, and cancer-related pains, and discuss a lot of the different methods by which we treat pain. So beginning with acute postoperative post-traumatic pain, one of the things that can be done to help in various cases are postoperative epidural analgesia. This can be associated with improved earlier mobilization, increased patient satisfaction, and often decreased cost. I've left some references there for you to describe where I've gotten a lot of the information from the up-to-date chapter has been very helpful in summarizing these things. The management of postoperative epidural analgesia is advantageous because it may reduce the need for systemic opioids postoperatively. It can be used for major abdominal surgeries, but please note that with epidural analgesia, if you're administering a hydrophilic opioid in the infusion, respiratory depression can occur up to 18 hours after administering that dose. When administering opioids via the epidural or the intrathecal routes, or any medicine, it's typically 5 to 10 times. Local anesthetics are often infused into the epidural space, as well as opioids. Commonly infused local anesthetics include bupivacaine and ropivacaine, and fentanyl hydromorphone. Often patients may have the ability to use what is called a PCEA, which is a patient-controlled epidural pump. One of the issues that may occur with epidural analgesia is the coverage can sometimes be referred to as patchy, in that it's not getting full dermatomal coverage. This can be treated with additional local anesthetic. I wanted to move forward and discuss a little bit further the use of neuraxial opioids. I mentioned earlier that respiratory depression can be delayed, as noted. Intrathecal doses for opioids and opiates have been used, as well as epidural. Note that the intrathecal dose is typically 1/10 that of the epidural dose. For example, typical morphine doses include 0.1 to 0.2 milligrams, 10 to 20 micrograms of fentanyl. It's important to realize which medicines may be lipophilic or hydrophilic, as the onset of analgesia will depend on this. It is thought that neuraxial opioids exert their mechanism of action on the mu receptors in the substantia gelatinosa of the dorsal horn. Typical neuraxial opioids are morphine, which is hydrophilic and ionized. Its maximum effect is in 45 minutes, and it may last for 18 to 24 hours via the spinal route. Fentanyl is a lipophilic type opioid. It typically can penetrate lipid-rich tissues. It may have a faster onset of action, but a shorter duration overall. So now moving forward, we'll discuss peripheral nerve blockade and catheters. There is a separate lecture about regional anesthesia that will provide information about this in greater detail. But in respect to the chronic pain disease states, I'd like to summarize that brachial plexus blocks are often used for upper extremity pain. Femoral popliteal blocks are used for lower extremity pain. Paravertebral blocks may be used for postoperative chest wall and abdominal wall pain. You may place these blocks via nerve stimulation techniques or ultrasound guidance. Sometimes these nerve block infusions are a single shot versus a continuous catheter infusion. And often it can be such that a patient can be given a preoperative bolus followed by a postoperative infusion. Another way to help manage post-traumatic pain is patient-controlled analgesia, which is a PCA. It's preferred for moderate to severe postoperative pain. Benefits are that the patients have more control, there's less chance of medication error, and it's titratable. Typical PCAs are morphine, hydromorphone, and fentanyl, which can be useful in hepatic and renal insufficiency. Morphine is likely not the ideal PCA choice for patients in renal insufficiency. PCAs allow continuous infusions along with opioid boluses. Other modalities to treat post-traumatic postoperative pain can include acetaminophen as listed, ibuprofen, PO opiates or opioids, alpha-2 receptor agonists such as clonidine and dexmedetomidine, which is not typically associated with respiratory depression, and anticonvulsant type therapy such as gabapentin or pregabalin. Other modalities can also include electrical stimulation such as TENS unit use. A TENS unit device uses electrical current to stimulate nerves for therapeutic purposes. It's generally applied at higher frequencies at 50 Hz. It's best avoided in patients with cardiac pacemakers, cancers, and pregnancy. Another way that postoperative post-traumatic pain can be managed chronically is spinal cord stimulation, whereby an electrical lead is implanted in the epidural space. This lead is connected to a battery-powered generator. It's often used for post-laminectomy syndrome, complex regional pain syndrome, and pain refractory due to ischemic changes. Moving forward, other ways to manage postoperative pain can include acupuncture, which is an alternative Chinese medicine using needles, heat, pressure, or laser to stimulate points. It's described as a technique for balancing the flow of energy or the life force known as the qi. It is thought that this physiologically may increase blood flow. Acupuncture is placed according to meridians and is not considered dermatomal. Its precise mechanism of action is unknown, and it has shown best results in postoperative pain, chemotherapy, and nausea vomiting. Another medication that can be used for postoperative pain, particularly in the opioid-tolerant patient, is ketamine. Ketamine is defined as a non-competitive N-methyl D-aspartate receptor antagonist. It is often associated with hallucinations and dissociative states, and it may help prevent chronic postoperative pain syndromes. Ketamine binds to mu and sigma receptors that are thought to suppress central sensitization. Side effects are multifactorial, including increased blood pressure, heart rate, arrhythmias, diplopia, nystagmus, increased intraocular pressure, tonic-clonic movements, and psychiatric side effects such as hallucinations, psychosis, anxiety, and dysphoria. Now we're going to shift to the treatment of cancer-related pain. We are following the outline as noted from the ABA keywords. The key to cancer pain is that it is multimodal. I'm giving a website listed here from the World Health Organization, and it describes multimodal ways to treat cancer. Pharmacologic strategies are really important in cancer pain, specifically for the treatment of breakthrough pain. Why do people get pain in cancer? Well, it can be the direct result of a tumor, such as bony involvement or obstruction of organs or compression of nerves. It may be an indirect result of the tumor, such as infections or metabolite imbalances or occlusions. It may be the result of tumor therapy, such as surgery, chemotherapy, or radiation, or it may be related from a whole subset of other pain conditions that could have been pre-existing prior to the cancer. Peripheral neuropathy occurs in cancer from metastatic issues such as spinal cord compression, metastases, non-metastatic issues such as metabolic, nutritional, and therapy side effects. Peripheral neuropathy is often seen in paraneoplastic syndromes in cancer, and there may be unrelated reasons to peripheral neuropathies in cancer such as diabetes and vitamin B12 deficiencies. When discussing the treatment of cancer pain, it's important to be systematic about using medications. It's important to select the appropriate drug, dose, route, interval, and to be sure to recognize and treat breakthrough pain appropriately. Often, cancer pain is difficult to treat, and aggressive titration of medications may be necessary, and anticipation of side effects is important. Most important in cancer pain is the concept of breakthrough pain, this is typically defined as a transient increase in pain that is greater than what was the stable pattern of pain. In cancer pain, it is important for short-acting opiates to be used that are typically in duration from 2 to 4 hours. A breakthrough pain short-acting opioid should have its effect hopefully within a half an hour. In general, this rescue dose in a cancer pain management should be 10% of the 24-hour baseline dose. Opioids may be used for spontaneous breakthrough pain that may be a fall-related or just movement-related. One of the things that can happen with chronic opioid use in any patient, whether it's cancer or non-cancer, are the following definitions, which are frequently asked about on the boards. Addiction is typically classified as an aberrant psychoactive substance that is used in a manner characterized by craving, loss of control, compulsive use, preoccupation, and continued use despite harm. It is associated with psychological or physical effects and typically also with withdrawal. Addiction is complex. It involves behavioral, cognitive, and physiologic components. Users continue to use their medications in an inappropriate way in the face of obvious physical or psychological harm. Addiction is also characterized by an attempt to avoid withdrawal. Pseudo-addiction is complicated to diagnose. It is a subset of patients who may resemble opioid abusers secondary to drug-seeking behavior. However, these patients may be under-medicated and they're only behaving in such a manner because their pain dosing is inadequate. The prevalence of pseudo-addiction is hard to note, and typically what is seen is increasing the doses usually eliminates the drug-seeking behavior. In contrast to addiction is tolerance. Tolerance is defined as when you have an increased dose of a psychoactive substance which is needed to produce a desired effect. Essentially, your doses are no longer effective. Tolerance can be the result of cross-tolerance, which may be the repeated administration of one psychoactive substance that is manifested toward another, for example, benzodiazepines and alcohol. Tolerance may be innate in that a patient may have a pre-existing insensitivity, or tolerance can be pharmacokinetic, which means that the patient's distributions or metabolisms of drugs, whether that's via enzyme induction or accelerations in metabolism, account for the ability to handle increased doses without effect. Dependence is different because dependence is defined as a way that a patient physically adapts to a medication. The hallmark of dependency is that once the substance is ceased, a withdrawal syndrome occurs. Dependency may be psychologic in that a patient may desire or seek its effects, perhaps looking at the clock psychologically. Dependence may also be physical, and the hallmark of that, as mentioned earlier, is that the withdrawal syndrome results when the substance is ceased. What we want to focus on next is the way cancer pain can be treated via spinal and epidural analgesia. This is often helpful for patients with limited life expectancies who cannot tolerate the systemic side effects of pain relievers. Different ways to infuse these medicines may be percutaneous for people who have a shorter life expectancy, tunneled to reduce infection risk, or implanted. There are implantable intrathecal pumps that can have fixed and programmable pump rates. Additives such as local anesthetics and clonidine can be used. Complications of these types of placements may include infection, respiratory depression, epidural abscess, meningitis, seromas, granulomas, and catheter migration. There are a number of neurolytic and non-neurolytic nerve blocks that can be used in the treatment of cancer pain. Celiac plexus and splanchnic blocks can be used for abdominal pain, Gasserian blocks for facial pain, superior hypogastric and ganglion impar blocks for pelvic pain, paravertebral and intercostal blocks for rib pain, fractures, chest wall pain, and abdominal pain. Typically, a neurolytic block uses a medication that destroys the nerve or nerve plexus, but also non-neurolytic blocks can be done as well, which uses usually a local anesthetic or a steroid. This is a more transient blockade. but it doesn't destroy the nerves. Neurolytic blocks can be used to essentially interrupt or destroy the afferent neural transmission. These are often done in cancer and end-of-life scenarios. Neurolytic blocks can also be accomplished with surgery, cryotherapy, heat, neurolytic agents, Wallerian degeneration, and risk of deafferentation pain can occur with repetitive neurolytic blocks, and this type of pain can be even harder to treat than the original pain. Neurolytic agents that are used for these types of block include ethyl alcohol, the mechanism of which is the nerve destruction and Wallerian degeneration. This type of injected ethyl alcohol, that is, causes more pain on injection, and there's a higher chance of neuropathic pain after the injection. Phenol is another neurolytic agent. Its mechanism of action is a coagulation of protein. There may be less pain on the injection of phenol. And glycerol is another neurolytic agent that can be used. Its mechanism of action is axonal destruction or Wallerian degeneration. It is milder and is often used for trigeminal neuralgia, mostly for Gasserian blocks. Other types of nerve blocks that are done include a celiac plexus block. This is typically done at L1. The celiac plexus carries afferent fibers from the upper abdominal organs that range from the stomach to the mid-transverse colon, including the pancreas and gallbladder. Celiac plexus block indications are typically for pancreatic adenocarcinoma or any cancer-related visceral pain originating in the upper abdomen, including a cholangiocarcinoma. Adverse side effects of a celiac plexus block can include transient or permanent spinal cord damage or paraplegia due to the spread of the lytic injected to the nerve roots, epidural space, or intrathecal space. An aortic puncture may occur. Disruption of the sympathetic nervous system typically results in unopposed parasympathetic tone. Therefore, the side effects of this block are typically diarrhea and hypotension, secondary to splanchnic vasodilatation. The superior hypogastric block is indicated for visceral pelvic pain refractory to medical management or any form of pelvic cancer. It is typically placed at the site of the superior hypogastric plexus. This is located at the anterior portion of the L5 vertebral body. When discussing cancer pain and using different types of medications, it's important to speak about the World Health Organizational ladder, which I referenced here with this website. So the World Health Organization ladder typically is such that you start with the lowest form of analgesia and not the highest, and that level 1 is typically acetaminophen, aspirin, or NSAIDs. If that pain persists or increases, you may add mild to moderate pain non-opioids adjuvants, and then progress to the next level, codeine, tramadol of opiates. If that level fails and pain is persisting or increasing, it is thought to advance to level 3, which are the more potent opioids such as morphine and fentanyl, while continuing to add non-opioids and other adjuvant medications. This is a newer adaptation of the WHO ladder from the NCBI website. It's important to note that you may bypass certain steps depending on the level of pain, and that you may also trial NSAIDs and procedures at any point, or neurosurgical procedures as well. So moving forward with the treatment of chronic pain, we've focused quite a bit on cancer pain. Now we're going to focus on non-malignant pain. We're going to go through the medications and the different types of blocks and other techniques that are often used. So this could be many, many hours of lectures, but we're trying to make this as concise as possible. So we use NSAIDs, opioids, anticonvulsants, and antidepressants. I tried to touch base here from this source of the mechanism of NSAIDs, which is typically the constitutive COX-1 blockade and the inducible COX-2 NSAID blockade. This diagram illustrates the mechanism of NSAIDs and where they work, and the molecules that are inhibited by these NSAIDs. So in discussing this, it's important to touch on the cyclooxygenase enzyme. It exists in tissue as a constitutive isoform, COX-1. At the site of inflammation, cytokines typically stimulate the induction of the second isoform, COX-2. So inhibitions of COX-2 are beneficial in the sense that they're anti-inflammatory. Inhibition of COX-1 runs the risk of GI toxicity. So Most currently used NSAIDs are somewhat non-selective, but selective COX-2 inhibitors are also available. NSAIDs are classified into many separate categories. I've listed them here as non-selective, including salicylates, acetaminophen, acetic acids, propionic acids, oxycams, and then COX-2 inhibitors are listed there as well. Ketorolac is an NSAID that acts on the central nervous system and also in the periphery. It is PO dosing, 10 to 20 milligrams daily. It is thought that not more than 5 days of PO dosing should be done, secondary to GI toxicity. IV dosing suggestions are up to 120 milligrams per day. However, please note that use of intense NSAID use can often be seen accompanied by GI side effects and, in worst case scenario, death by operative site bleeding. Ibuprofen is the prototypical NSAID. This is seen in formulations such as Advil and Motrin, is well absorbed, metabolized in the liver. Its analgesic effect has a cap, most likely at 1,200 milligrams per day. Side effects include nausea and dyspepsia, and renal side effects may occur that are often dose-dependent, seen in the elderly. Ibuprofen also antagonizes the irreversible platelet inhibition induced by aspirin. So patients who have increased cardiovascular risk, ibuprofen will limit the cardioprotective effects of aspirin. Next, we're going to move toward opioid receptors. Opioid receptors are listed below. These are the 5 most typically seen. Mu1, which is associated with supraspinal pain mediation. Heart rate decreases, sedation, and pruritus. Mu2, respiratory spinal depression, physical dependence, euphoria, and pruritus, as well as urinary retention. Kappa, which is spinal anesthesia. Sigma, which is often associated with the sympathetic side effects, such as increased heart rate and blood pressure. And delta, with less respiratory depression and spinal analgesia usually seen. Side effects of opioids are multiple. They may relieve anxiety, euphoria, and dysphoria, but cause mental clouding, sedation, pruritus, constipation, urinary retention, nausea, vomiting, respiratory depression, pupil constriction, antitussive effects, androgen deficiencies such as testosterone decreases may occur, and in the OR setting may lead to decreased heart rate, blood pressure, and pulse oximetry. Morphine is the prototypical opioid. Its half-life IV is 3 hours. It's hepatically metabolized by glucuronidation. It's available in PO forms and short and long-acting. Chronic morphine therapy can result in tolerance, addiction, and hyperalgesia. Morphine 3-gluconide has been associated with hyperalgesia, which is a heightened awareness of pain, thought to be caused by the opiate itself. Morphine 6-gluconide is a typical metabolite that is eliminated by the kidney. However, in patients with renal insufficiency, this can accumulate. Thus, other opioids should be considered in patients with decreased renal function. Dilaudid is a shorter half-life opioid. It can be seen in the oral or parenteral formulations. It is semi-synthetic, is more potent than morphine, and is advantageous for the opioid-tolerant patient. Another opioid used is methadone. Its use has increased in recent years. It's thought to be helpful when dealing with patients who have tolerance. It is advantageous in that it is inexpensive. There are no apparent toxic metabolites. It may also have NMDA receptor antagonist activity. However, it has a longer drug half-life which can lead to accumulation. It may also prolong the QTC interval, leading to torsade de pointe. It also has a stigma in that it is used in addiction and is not typically recommended as a first line in cancer pain for breakthrough pain because of its slow onset. Codeine is what is referred to as a prodrug, in that it is extensively metabolized in the liver. A portion of it is demethylated to morphine for its effect. It is metabolized by the CYP2D6. It is a weaker analgesic, used often for antitussive or antidiarrheal uses. Fentanyl is a much more potent opioid in that it is lipid soluble. It is commonly used with local anesthetics for epidural analgesia. It is also available in the transdermal formulation. It is more ideal for labor analgesia in the epidural route because it has a rapid onset of 5 to 10 minutes and a short duration of action. Meperidine is an opioid that is associated with the metabolite normeperidine, which is often seen having a unique neurotoxicity that can lead to grand mal seizures. It's also problematic because its metabolite half-life is longer than the parent compound. Therefore, its half-life is prolonged in renal failure. Meperidine is falling out of favor as a commonly used opioid, secondary to all of the above. It is often used for shivering treatment in the PACU, however, this mechanism is unknown. Contraindicated also with MAOI inhibitors. Anticonvulsant therapies are a separate category of medicines. They're thought to reduce the ability of the neuron to fire at high frequency. It is thought that they act by enhanced gamma aminobutyric acid inhibition, or have a stabilizing effect on neuronal cell membranes, or NMDA receptor sites. Gabapentin is a commonly used anticonvulsant. It is synthesized to mimic the GABA neurotransmitter, but is not believed to act on that GABA receptor. Its exact mechanism is unknown, but is thought to be involved with voltage-gated N-type calcium channels. It has been used for postherpetic neuralgia, a variety of neuropathic conditions, and complex regional pain syndrome. The most common side effects are dizziness, drowsiness, peripheral edema, hepatotoxicity, and it needs to be also renally dosed. Pregabalin binds to the alpha-2 delta site on a subunit of voltage-gated calcium channels present in CNS tissues. It is indicated for diabetic peripheral neuropathy and postherpetic neuralgia, as well as fibromyalgia and epilepsy. The dose titrations are listed as noted in the slides for your reference. Baclofen is an activator of the GABA B receptor. It is used for spasticity in spinal cord injuries, cerebral palsy, and multiple sclerosis. Its mechanism of action is thought to inhibit the transmission of both monosynaptic and polysynaptic reflexes at the level of the spinal cord by activation of the GABA B receptor. Treatment of chronic pain and chronic pain syndromes frequently involve the use of antidepressants such as TCAs, SNRIs, and SSRIs, all of which are listed there for your reference. SNRIs include duloxetine, venlafaxine, and milnacipran. These types of medications are often used for diabetic neuropathy, fibromyalgia. Antidepressants are used frequently. SNRIs and TCAs have demonstrated consistent efficacy in neuropathic pain and fibromyalgia. Analgesic effects are not achieved rapidly. It may take several weeks for these things to be noted. The analgesic effect is typically achieved at a lower dose, and the SNRI category of medication have been shown to typically be better tolerated with respect to side effects than the TCA category. Moving on to the treatment of chronic pain, spinal and epidural analgesia can also be used for chronic pain treatment. Intrathecal modalities can be used and epidural modalities can be used. In comparing the two, intrathecal dosing avoids supraspinal mediated toxicity, is typically 1/10 the dose. A disadvantage is that it may require a disadvantage is that with the dural puncture, the drug has an increased risk for meningitis and post-dural puncture headache, but the delivery of the drug is much closer to the spinal receptors. In contrast, epidural infusions are typically slower. They do allow for dermatomal placement without a dural puncture, but it may require a larger dose. Here are the layers that you have to pass through in order to reach the epidural space. This is a test question that's frequently asked. It goes all the way from the skin to the core, so I've listed them all right there for you. I won't read them all, but they're there for your reference. So moving on to the treatment of chronic pain, one of the most common things done are lumbar epidural steroid injections. Typically, these are done for the treatment of lumbar radiculopathy. An epidural steroid injection is a localized medication delivered to the area of the affected nerve root. It decreases the likelihood of potential systemic side effects that can be seen with PO steroids. It's mostly helpful for the presence of an acute nerve root inflammation. It's an integral part of the non-surgical management of radicular pain from lumbar spine disorders. Radicular pain is defined as a sharp, lancinating, radiating pain from the lower back down into the lower limbs in a radicular distribution. It is a result of a nerve root lesion and/or inflammation. These nerve root inflammations can include radicular pain, dermatomal hyperesthesia, weakness of a muscle group, diminished DTRs, and positive straight leg raise tests. In addition to epidural therapies, there are intrathecal drug therapies that can be used for cancer pain or greater than 3 to 6 months life expectancies as well. In patients with severe cancer pain, intrathecal drug delivery can reduce opioid toxicity and prolong life. It is indicated for chronic non-malignant intractable pain that has been failed with conservative therapies, and its indication for severe spasticity, such as intrathecal baclofen, that was not managed well with oral medications. The currently approved intrathecal drug delivery systems for delivery are morphine, baclofen, and ziconotide. We've covered morphine and baclofen, but ziconotide is a hydrophilic molecule derived from the toxin of a cone snail species. Its mechanism is a selective N-type voltage calcium channel blocker. It also is thought to inhibit the release of the pro-nociceptive neurochemicals like glutamate, CGRP, and substance P. We are going to have to defer to the regional anesthesia lectures for the history of all of the different types of peripheral nerve blocks that are done. Now I'm going to go through some of the nerve blocks that we do for chronic pain. A lateral femoral cutaneous nerve block is typically done for a syndrome called meralgia paresthetica, which is a band-like type of pain located on the lateral thigh. This is done by identifying the anterior superior iliac spine, and then approximately 2 to 3 centimeters medial and inferior, a needle is placed, which is a combination of a local anesthetic and or steroid. Next, I'm going to discuss a lumbar sympathetic nerve block. The indications for this include CRPS, neuropathic pain, inoperable peripheral vascular disease, cancer pain, and phantom pain. It is located at the anterolateral corner of the L3 vertebral body. It can also be done at L2. A successful lumbar sympathetic block can occur and be accompanied by vasodilation and an increase of 2 degrees Celsius in the leg. Complications of lumbar sympathetic blocks can include blockade of the L2 somatic nerve root, an inadvertent injection into the subarachnoid space, damage to the kidneys, renal, pelvis, ureters, or discs, infection or backache, and some less commonly seen things as listed below. A stellate ganglion block is typically used for the diagnosis and treatment of CRPS of the upper extremity. It also aids in the increased perfusion to the upper extremity. Typically, a local long-acting anesthetic is used. Here's a picture of the stellate ganglion anatomy. The stellate ganglion is somewhat of a misnomer. The stellate ganglion itself is the fusion of the lower cervical ganglion and the first thoracic ganglion. It is approached at the C6 transverse process. The landmark is typically the cricoid cartilage at the Chaussagnax tubercle. The stellate ganglion is actually located below. It's a misnomer in that where we place the block relies on caudal spread. As you can see here is the C6 region whereby the nerve block is placed. Here are some accompanying structures that need to be avoided, such as the vertebral artery. We'll go through all of the complications of a stellate ganglion block in just 1 second. Things that can occur with stellate ganglion blocks that can be normal and expected are local anesthetic spread to the phrenic nerve, such as shortness of breath, respiratory compromise. Therefore, bilateral blocks are not indicated. The spread of local anesthetic may also go to the posterior tubercle. That may result in upper extremity sensory loss and upper extremity motor loss. The spread of local anesthetic may also spread to the recurrent laryngeal nerve, where hoarseness, a lump in throat, and difficulty swallowing may occur. A lot of these types of problems are not life-threatening and are common. However, more serious types of side effects are intravascular injections, which may result in a generalized seizure, a carotid artery injection, as the carotid artery is anteromedial to Chaussagnax tubercle, and the vertebral artery is posteromedial to the Chaussagnax tubercle. A neuraxial block may occur if there is accidental injection of the local anesthetic into the epidural or spinal space, resulting in a loss of consciousness and apnea. Signs of a successful stellate ganglion block can include anhidrosis, nasal congestion, venodilatation in the hand and forearm, an increase in temperature of the block by at least 1 degree Celsius, and a Horner syndrome, which is typically the constellation of meiosis, ptosis, and enophthalmosis. The definitions of all of those are listed below. I wanted to go over some other TENS units type informational things that I didn't maybe go over before. TENS unit devices are used frequently in the treatment of chronic pain. It's a use of electrical current. It's generally applied at frequencies higher than 50 hertz and is best avoided in patients with cardiac pacemakers or cancers. Spinal cord stimulation is another method by which electricity is used to treat pain. Typically, a spinal cord stimulator is trialed for approximately 3 to 7 days, in which a lead is percutaneously placed into the epidural space. The lead itself transmits a pulsed energy to the dorsal column of the spinal cord to alleviate pain control. It is thought that this inhibition via electricity is following the Melzack and Wall gate theory of pain. Spinal cord stimulation is often used for neuropathic pain, angina, however, this is not on label in the United States, and peripheral ischemic pain. I touched just right now on the gate theory of pain, and I wanted to further describe that. It was formulated by Melzack and Wall in 1965. The gate theory of pain is typically, painful stimuli are typically carried by the C and A delta fibers to the substantia gelatinosa and the dorsal horn. However, it is thought that blocking this stimuli via A beta fibers in the dorsal horn can help decrease pain. That is how the mechanism of spinal cord stimulation is thought to work. There are other mechanisms by which spinal cord stimulation is thought to work that include suppression of hyperexcitability of wide dynamic range neurons. It is thought spinal cord stimulation may increase GABA and serotonin, may suppress glutamate and aspartate. It may alter sympathetic tone and reduce activity-dependent neuronal excitability. Radiofrequency ablation is another technique that is used for the treatment of chronic pain, whereby a high-frequency alternating current flows from the electrode that causes a neurolysis of the nerve through thermocoagulation. This may reduce pain through modulating pain transmission. However, it is not typically associated with signs of current permanent nerve damage. It is used through heat, mechanical friction, and is typically done at a current alternating at 300 kilohertz. Surgical neurolysis involves freeing and or hardening the nerve, while surgery involves removing the affected nerve. We touched earlier in the presentation about neurolytic substances, such as ethanol. To harden it, injections may be administered once a week or once or twice a month to destroy the nerve and alleviate the symptoms. This concludes the chronic pain medicine portion, chronic pain disease states. Thank you very much for your attention.